Thanks very much, Miltos. So quickly before we come into some really nice video, we're going to talk about briefly about endophthalmitis, TASS syndrome, and CMO. But just connecting with Miltos's topic now, because it's always nice to hear about what is coming. Every time you go to the big conferences, you sometimes take almost nothing away. You think, well, why did I turn up? But this year, when I went to ESCRS, I saw something really amazing that I want you to check up if you have the spare time. So if you write down the name Liliana Werner, that's W-E-R-N-E-R, and you look for her recent publications on a femtosecond laser system that adjusts the power of the lens. And this is just amazing. It's taking a standard lens, like the ones we're implanting now, and it's using a laser to modify the chemistry of the lens, like 3D printing, to change the hydration so as to induce optical changes in the lens. You have to see this to believe it, but it is incredible. And they were able to print a diffractive pattern through the lens and adjust the lens power, and also add multifocality to a standard monofocal lens after implantation. So I think that's a story that may well really be exciting, but we'll see. Anyway, back to the scheduled transmission very briefly. Endophthalmitis, it's about somewhere between 1 in 2 and 1 in 3,000 in most centers now, so not so common, thankfully. And what are the risk factors? Well, again, the Mats Lundström and the Swedish registry have got some good data on this. If you're over 85 years old, therefore, I presume relatively immunosuppressed, and you maybe have a denser cataract too, that's a risk factor. And don't rupture the capsule if you can avoid doing it, because that increases your risk significantly, 5 to 8 times. And if you don't use intracameral antibiotics, I think we all know now that that's a risk factor, okay? What is not a risk factor for endophthalmitis? It doesn't matter what gender you are. It doesn't matter what IOL you use. Nobody uses the, was it polyimide haptics that used to be a risk factor anymore. And interestingly, there's no difference in wound placement. There used to be this story about put the wound superiorly to avoid endophthalmitis. That's not true, okay? And so here's an interesting thing you might not be aware of, though. You should be going underneath your lens optic to do your I&A at the end of surgery. And the safest way to do that is I think, to use a coaxial irrigation system with the irrigation coming straight out in front of it, like the old-fashioned Simcoe, which is what I use. But I'm sure you can do the same maneuver with bimanual systems or whatever you prefer to use. But go under the optic to remove the viscoelastic. Why do we think that's important? Well, there's a publication down underneath here. Again, you can photograph this slide if you want to. And this is really interesting, as it brings us to TASS. This is a cohort of patients that were studied, 9,000 in Japan, after they had a TASS outbreak with a particular lens. And so really it's a prospective cohort. And they were able to, they had quite a well-controlled list of outcome measures that were collected, including the way the surgery was done, like where the wound was placed and everything else. And the thing that came out as being a significant factor protecting from endophthalmitis was removal of viscoelastic from beneath the lens. So worth looking at that paper, because it might modify what you do if you're not doing that routinely already. And it makes intuitive sense, doesn't it? When we inject a lens, we often see mucus dragged in underneath it, and we often have a little bit of retained viscoelastic underneath the lens. So remove it, and then you'll have a reduced incidence of endophthalmitis. Read the paper, very interesting, something we can do. So what can we do? We also know that povidone iodine in the fornix for at least 2 minutes before the surgery is very effective in sterilizing the conjunctiva. Preoperative antibiotics, by the way, don't work. It's just really encouraging resistant organisms. And the IO beneath the IOL optic, we mentioned that, and you must be using intracameral antibiotics these days. There's a question mark about whether you do anything in addition for cases that you know to be vulnerable, like somebody who's over 85, say, or somebody in whom you have had a posterior capsule rupture. Do you add a 5-day course of oral moxifloxacin as if you were treating for endophthalmitis? I don't know the answer to that, but it's a question that's been raised. TASS syndrome. Here you really have to rely on your institution and have good governance, good control over sterilization processes, only using pre-mixed drugs that are manufactured and CE marked according to good manufacturing practice. These are all things that protect you from a TASS outbreak. And as you know, this is endotoxin in the eye or another toxic insult to the front of the eye. How do you distinguish it from endophthalmitis? It's because it comes on straight away, okay? It's there the next day, whereas endophthalmitis, it's 2 to 3 days after surgery. So it's typically a lot of fibrin, typically quite a bit of corneal edema too. And so that's TASS syndrome. Best avoided, and as I say, the ways to avoid it are to stick with drugs that are batches of fluids that are manufactured according to GMP guidelines, and also to have good sterilization protocols. You need your institutional governance to be working. What about immediate sequential surgery versus bilateral surgery? Well, you can form a view of that, but if you are going to do same-day bilateral surgery, you should be having separate instrument trolleys and separate fluid batch numbers and drug batch numbers, okay? CMO, last thing, weak area for me. Some people are very kindly helping me out at the lunchtime session here, educating me on this, because we get OCTs coming through before cataract surgery all the time now, showing something that didn't exist when I was doing my residency, which is vitreomacular traction. And what do you do about that? Well, it's possible that's a risk factor for CMO, so using prophylaxis with non-steroidal drugs. But we should probably be doing that for everybody. If you look at the results of the pre-med study, then it tells us that, in fact, there's a good evidence base now for using non-steroidal drugs just before the surgery and for 2 weeks afterwards, so for 2 days before and 2 weeks after. And that's helpful not just in diabetics, it's helpful in everybody, okay? 3 times less risk compared to dexamethasone alone. So if we're up to speed with the literature, we should be doing this. And so it's certainly something you should look at, and we should be looking at it too, Vincenzo, because we're not doing it routinely at the moment at Morpheus. Maybe we should be. So I'll leave it there. And we'll move on to some exciting video, I think. Is that right, Miltos, next? Are we on to the videos now? Yep. Great. Okay, so enough of the didactic stuff.